is called one abutment, one time. It's been described by Luigi Canullo and many other authors in the literature. The way to change the emergence profile that you will discover later on is called biologically oriented preparation technique. It was invented by Ignazio Loi. Why do we place immediately the abutment where we can? First of all, it will reduce the costs for the patient. She will not have to pay more elements in order to place a provisional. But this is not a reason. The reason is this one. Abramson made an experimentation. I'm sorry it's on animal, but the story is quite interesting. He places implant to dog right and left with healing screws on top. From one side, he removes the healing screws, counts 1, 2, 3, and then put back. From the other side, he don't touch. 5 disconnection during 6 months. What happens is that in the side where he was removing and replacing 5 times the healing screw, he had a resorption of the bone and the tissue had a recession. In the place where he didn't touch the connection and he didn't contaminated the healing screw, nothing changed. Tissue was very stable. Please remember what kind of connection is this. It's a very old connection, flat to flat, external hexagon. Cochrane didn't trust it, and he did the same protocol, and he had the same result. Berlung did not trust it and made the same protocol and had the same result. Recently, Linde again made the same experimentation, and all 4 scientists had the same result. We can think that this can be true, perhaps. The less you disturb tissue around implants, the more they are happy. So I immediately place the provisional with the final abutment. The provisional rule has an emergence profile that has to guide the maturation of this tissue. And this is after 1 year. We had a little bit of shrink, of loose. If we make a comparison, you see that there is a reduction. Always happen. This is normal. Araujo says this very clearly. But now you can understand that positioning the implant more palatal, I have more thickness of tissue here compared to natural teeth. If I place the implant in the middle, now I would have a recession. So please always place the implant in this position, palatal position. This is the replica of the abutment that the technician did. He did the replica with epoxy resin at low shrinkage, and he created this precision cap that snap on top of this abutment. There's no shoulder in this abutment. This is the analog. Shoulderless. So I can choose in the future where I want to finish my prosthodontic. I put the cap, I take the impression of the position of the cap. The technician takes the replica and put back. He can create the tissues. It's a very cheap way to create prosthodontics, this one. And this is zirconia ceramic crown. And again you see the notch, the palatal notch to remove it, because perhaps in the future I want to remove it. And you can see the very horizontal emergence profile. This is at 1 year. If you make a comparison, tissue seems very stable. But look what happens over time. After 3 years, it grows. Why? The emergence profile and the thickness of tissue, before it was concave, and after it becomes convex. It grows alone, guided by the prosto. And you can see a nice root which is coming alone. After 4 years, I had the chance to make a CBCT because the patient had a problem somewhere else, and we can verify that this dimension 4 years later is approximately 1.8 millimeter. 5 years, even better. 6 years. It's very stable over time. And the bone peak too are very stable. Perhaps the socket preservation that it was effective to obtain this, but I need some data, some parameters to understand why the tissue was growing. We all know when we extract a tooth, we will lose the buccal plate. This is well described by Araujo. Many other authors. So you always have a recession. Almost always. But if you graft with low resorbable rate material, this is one of the few situations where autogenous bone is not recommended, because the remodeling is too fast. It's critical to know the distance between the implant and the bone. This distance should never be less than 2 millimeters. This is the minimum. Better 3, perfect 4. I repeat, because it's very important. The distance between the implant and the bone, minimum 2, better 3, perfect 4. So you take this number and you stick a post-it here, in this point. We will go back later on this number. Because we can obtain minus 23% of the horizontal resorption. The one who are in the front can still see the presence of the graft. Then we have something which is very difficult to use. And it's the third choice for grafting, which is the tuberosities. The tuber is huge most of the time. And if you don't have the wisdom, probably you have 7, 6, 8 millimeter of very thick tissue you can harvest. But the character of these cells is totally different from all the others. That's why it's very difficult to use it. There's a large amount of dense connective tissue. There's no fat. The sensitivity is very little if you grab from there. When you eat, you harm yourself often there. You don't even realize it. You don't feel pain there. Because it's masticatory mucosa. Harvesting is very easy and very fast. 1.5 millimeters far from the teeth. And never, never, never cut the soft palate. It's the only rule you have. Then you deepitalize it. Be careful, because it's very white. In aesthetic area, you can only use bilaminar inside local tissue. But I want to show you a mistake case to understand how dangerous it can be. It's like a beast. When we remove this tooth, there is a cavity here, an infection everywhere. So we remove, then we have to remove this granulation tissue, cleaning very well, also with antibiotic inside the root. And then I place an implant here. This is another very old case, so you see old implants. And here there is a gap. And I will grab from the tuberosity to fill this gap. There is a collapse. And here it begins growing. I want to use this volume to reduce the collapse with the provisional. I don't like collapsing here, because if you leave a minus of volume there, it's not a problem of aesthetic. But every time you eat, the food will stay there. And it's not good to have food who stays just next to the implant the whole day if they don't brush. And it's very ugly to see the patient after eating that do strange things with the tongue to remove the food that stays here. That's why I like to place volume here, even guided with the prosthodontics. So here the line is perfect, but here begin to growing. He's pregnant. Okay? And the volume gain back the original volume. I'm sorry I'm not going there, but there is this, and if I come here, and you understand why I'm not staying here. Sorry, I will stay that way for this reason. But I'm talking to you the same. Don't be offended. Look after 3 years, how much it grows. After 3 years, the tuber is eating the zirconia. Imagine this happens in the frontal area to a beautiful woman. You would kill yourself. And I tried to cut it. It went back bigger than before. There's no way to fix this. Actually, there is. It's prosthodontic. If my technician increase the volume here, it push up. It will increase only horizontally. You see the time pass for sure. Here there's no recession. And here there is an abrasion and a recession. This lady has recession problem, but he grows. And this is 5 years later. Even worse. This is time passing by the truth. It's not fake timing. You see? So be careful, because the tuberosity has the power to increase the volume. But sometimes we need volume. So I want to learn how to use this volume in a predictable and safe way in frontal area. What is the phenotype? Can I ask you to read to them? Thank you very much. Everybody speaks about biotype. Biotype is the full body behavior. There are thin and long who have lung problem, who are shy, and there are large and little who have heart problem, who are irruent. This is a description of the characteristic of the single cell or a single group of cells. And this is the first article that evaluated this at human histology and clinical measurements. It's very well done. And at the histologies, you could see that the tuberosity, of course, gives a hyperplastic response. It will increase the volume over time. And more into detail, this volume will be very strong and very thick. It augments the production of collagen type 1. That's why it's very wide. The number of vessels is very little. So I want to try to use it in the frontal area. But again, I want to show a mistake case, so you're not doing the same tomorrow. This lady has a tooth broken. So I asked her for 3 days, chlorhexidine, rinsing, and hygienist. They prepared the mouth. This tooth is broken. And it's a very difficult case because the aesthetic is perfect. And she shows 100% while smiling. And she's very handsome, beautiful. There is a perfect symmetry between the two incisors. And I was scared about this case. So I thought in my mind I will do everything I know in order not to have a recession. But because of this, I made my mistake. Because I was trying to keep this, but I didn't notice that this is a very thick biotype. So a socket preservation and implant positioning will be more than enough. I wanted to do more, and this was my mistake. This is the part broken. If only this was a problem, I would have kept the root. And I would have done orthodontic extrusion. But there were other fractures inside. There was no way to keep. You see? This is all exploded. So I had to remove. We preserve very well the volume all around. You see, papilla are correct. They are not destroyed by my levers. It's very difficult to do a traumatic extraction. It takes for me half an hour to do a traumatic extraction. And 1 minute to place an implant. Here's the implant in place. The ideal positioning is slightly distal in correspondence to the zenith that we want to create, with a slight convergence to the middle line and very palatal positioning. The end of this black is number 4 millimeter depth. Another time we take this number 4 and we write in our post-it that is still here. Okay, keep your post-it here. So, palatal positioning, slightly distal, in correspondence to the zenith, and little convergent, as the natural root are, the same. It's very good stability. Remember that torque is not stability. We will see this later. So I put my medial abutment. I shape it and polish. Remember, after polishing, you have to clean this very well. Very, very important. Soon will come out an article that I wrote on the Nevin's paper. 5 minutes in ultrasound with demineralized water is more effective than plasma. So it's a very good decontamination habit. You have to decontaminate from bacteria, but especially from waxes, greases, and whatever dirt is on top. In alternative, you have a machine which is called McClean, and I don't know if you have this, McClean. I don't know. So it has ultrasounds and plasma and everything that decontaminates this very well. If the prosthetic components are contaminated, the tissue will not stay there. Remember the studies that I showed you from Berlon, Galberson, and Linde, and whatever. This is the provisional, relined. It's my choice to reline it without silicone dam. Even if I suggest for the one who are not experienced to use always a barrier. Because if the resin goes and touches the implant, you fail. This is the emergence profile, very horizontal. We will talk about this later. I place some bovine bone in the buccal bone. And my mistake was I placed too much. So I took a little piece from tuberosity. Very little. This is 2.5 millimeters, a beaver blade. 2.5 millimeters, 4 millimeters. It's very, very little. I put it there after depitalization. But my problem is that because I placed too much bone under, the graft was too much on the surface. You see, the graft is not inside. My beast is not inside. So I use the provisional to push it up. And up to now, everything seems very good. But my problem is that I didn't see this. The beast is not inside, he is outside. I left a way to come out. It seems very little, but it can do disasters. One week. At 1 week, I discovered what was going on. This is 2 weeks. But now it's too late. I can do nothing. You can see from the inside it's growing, behaving like a tumor locally. This is 2 months later. It's beginning growing. 4 months later, growing again. 6 months later,